Good evening, everyone. We're going to start the meeting in 2 minutes time. So we're just going to wait a little more for some persons to come in, and then we're going to start in 2 minutes. Good evening. Before we get into our webinar today, we have some housekeeping matters to get out of the way. First, I would like to ask everyone to keep their mics muted in order not to disturb the presenter or anyone that is speaking at a particular time. You can feel free to send your questions throughout the presentation so that we can move right into the question and answer segment right after. If persons are in the Zoom meeting, you do not need to join in on YouTube. So you can choose either YouTube or Zoom. Additionally, those of you joining us on YouTube, please note that there's a 20-second delay, so give us some time to respond to your questions if you would. Thank you very much, and let's get started with today's webinar. Someone has their mic on. Okay, let's go. Trustees, executive members, staff, members of the Diabetes and Hypertension Association of Barbados, specially invited guests and presenter Dr. Laura Lovell. Ladies and gentlemen, good evening and welcome. My name is Shari Harris, the second vice president of the association, and I will be your host this evening. This evening, I would like to introduce you to our trustees, executive team, and staff, and some of them are here with us online because we're both on YouTube and Zoom. Our trustees are Canon Wayne Isaacs, Mr. Keith Wilson, Ms. Trudy Griffith, who is also our president and a trustee. Ms. Annette Clark is our first vice president. Ms. Karan Griffith is our treasurer, and Ms. Kim Clark is our public relations officer. Our staff is Ms. Stacia Brewster, who's our office administrator, and Mrs. Sonia Luesi, activity coordinator. We will now move on to our agenda for this evening. First item up is a presentation by the Diabetes and Hypertension Association of Barbados.
Remember to unmute, Sherry, please.
Sorry about that. Thank you, Madam President, for that video. We're going to go back and just go through these housekeeping matters once more, because I found that some persons still did what we asked not to do. So kindly keep your mics muted. Feel free to send your questions through the presentation so that we can move right into the question and answer segment right after. If persons are in the Zoom meeting, you do not need to join in on YouTube. Those of you joining us on YouTube, please note that there is a 20-second delay, so give us some time to respond to your questions. And one additional one is, if you see that your name is Stacia Brewster, you can rename your image. You can rename your image by clicking on the three dots next to your photo at the bottom of the list. Click rename, put in the correct name and save, and you will then see your name come up. So that's for those of you that want to change your name from Stacia Brewster to what your name really is. Thank you. Moving on our agenda. Now, before we get into our presentation, which is up next, a lot of you may have this question in mind. Who is Dr. Laura Lovell? Yes, we know she's a doctor by name, but we need to know more about what she does. After graduating from the University of the West Indies with her medical degree, Dr. Laura Lovell has worked with diabetes at a multidisciplinary center where she still practices. Let me say that again. After graduating from the University of the West Indies with her medical degree, Dr. Laura Lovell has worked with diabetes at a multidisciplinary center where she still practices. She also holds a Master's of Science in Diabetes Care from the UK. Her love and passion for diabetes care started at an early age after seeing her aunt, who lives with type 1 diabetes, injecting herself with insulin as a means to survive. Ensuring that all patients living with diabetes have a good quality of life and their lowest risk of complications is her life goal and passion. Dr. Lovell has more recently relocated her private practice to Hearts Gap in Hastings Christchurch. It is my distinct pleasure to introduce to you Dr. Laura Lovell, presenting on the topic, Living Well with Diabetes During the COVID-19 Pandemic. Good evening, Dr. Lovell.
Hi, good evening, everybody. I don't know if my video is not on. Right. Hi, good evening, everyone. So today, it seems like there's not only COVID now, you have COVID, you have volcanoes, there's so many other things that kind of get in the way with living with diabetes. So that's what our presentation today is going to be about, okay? Just about to share my presentation. I apparently can't share, so I'm not sure if the technical persons want to share it from their end, because it's not allowing me permission to share my screen.
Okay, just give us a minute, Dr. Lovell.
Okay. Perfect. So everyone is seeing the presentation? Is it okay?
Yes, please.
Yes.
Okay, great. So the whole focus with diabetes is living well with it. It doesn't matter if there's a COVID-19 pandemic. It doesn't matter if there's a volcanic eruption. It doesn't matter if there's water outages. The whole focus is to live well if you have diabetes. So next slide. It seems that if everything has been thrown at us over the past 12 months for us to not live well with diabetes. So there's job losses because of COVID and other reasons. There is no COVID-19 in and of itself, any fears associated with COVID-19. There's a volcano and the stress associated with that. And I even put this one in here. I don't know if you remember, but there were water outages in certain districts last year. And I actually had some patients telling me that the water outages were allowing them to have poor diabetes control. So there's so many factors. It's about navigating through all of those life events, how you're going to have the best diabetes care possible. So next slide. Right. So you might ask, why is my checkup now needed more than ever? And the first reason I always say is because diabetes changes. Just because your control last year was great does not mean that next year it will be the same thing. It also doesn't mean that the medications you've been on for the past 10 years will work next year or even next month. So it's very important that you always keep on point with your diabetes checks and with your level of diabetes control along the whole stream of everything. The next reason is because complications still occur. So I've also had persons tell me, well, they told me to stay home, so I am not going to the doctor. Or they told me to stay home, so I'm not going to the pharmacy to collect my medication. And the truth is, you not being able to fulfill those normal requirements also now puts you at risk of complications from the same diabetes and hypertension, because complications still occur. We are still having strokes, we're still having feet, we're still having all these other things. So those are very important. And they are other things than COVID. So persons say, I'm not going to the hospital because in there got COVID. But alas, if you have an asthma attack or you have a heart attack or whatever, and you decide that you're going to refrain from going to your healthcare practitioner because of the same thing, that is not going to end well, right? Next slide. So the first step is that diabetes changes, and there is no way to see how your lifespan with diabetes is going to be compared with somebody else. So some person might be on tablets for many years and they're very well controlled. And then somebody else at diagnosis might require insulin. Why that happens, we're not entirely sure because there are many factors at play. So when you are diagnosed with diabetes, you may have had it many years. When you're diagnosed with diabetes, it might just be a very sudden change that happened. Like if you were on medication such as steroids and then you had gotten it after. But the fact is that it changes and it's very individual. So you can't say, wow, it's 10 years now, I will need insulin. Somebody might just be on tablets forever. Some persons might require insulin at onset. So to be able to see where you are, you still need to get checked along the whole pathway of your diabetes life, right? So the next step. The next slide. So just to be clear, before that, just to be clear, there is one measurement for diabetes generally used. Obviously, with everything in medicine, there are many ifs, nots, whatever. But the HbA1c is your average blood sugar reading over the past 3 months. And that is a very good idea of where you are along your level of control. So if you are like some persons and have been refraining from going out the house since last year, including going to your doctor, your HbA1c from last year, February, is probably not going to be the same as the HbA1c is this year, April. So if that is less than 5.7, that's generally normal. Between 5.7 and 6.4, you have prediabetes. And a diagnosis of diabetes is made anything above 6.5. But it's important to know that the level of control or the HbA1c for the person is individual. So I would not say that somebody at the end of their life needs to have an A1C of less than 6.5, for instance, because you have to look at the overall picture of the person. Very young, healthy persons, you want to have it as low as possible because that's associated with the lowest risk of complications. But it's very important to keep that level of control as tight as possible. Okay? Next slide now.
Oh, you can't hear them. No, listen, she, You can't hear them. Yeah, she.
Okay, and then the next thing is that complications still occur. Can I remind people, if there's one thing you don't take, you take home. People still having heart attacks,
Yeah.
they're still having strokes, they're still having all these other things. And the funny thing is that many studies are now finding that not only in Barbados, but in other countries, in US and the UK, for instance, because people are not going to their primary care doctors as often, they're not going to get their general checkups, their routine checkups. They're only coming if something is dire, something is definitely wrong. Then the American Heart Association is actually predicting that we're going to see a wave of persons in the next years and months to come with heart-related disease. So with heart attacks, with strokes, with hypertension. And that may be because of some things that have happened during this pandemic, right? The next slide now. The next slide. Right. So I call this the lockdown lifestyle. We are told this, we are told to stay at home. We are told you can only exercise within very strict times. We're told you can't exercise in large groups. And these are necessary for the pandemic itself, but then it leads to a very sedentary lifestyle. So these are the things that we were told for the last how many ever years to avoid. Go outside, get fresh air, make sure you exercise regularly. And these things are now kind of the reverse. So you have to balance, how do you control a pandemic and how do you fulfill orders that have been put in place to control the same said pandemic with these boundaries put on you. And can I add in here the access to fresh fruits and vegetables, which is something that is now restricted, not only because most persons may not have the income to be able to afford to buy them, but of course, you're now going into lines and so on to be able to go and purchase these things. So the persons who need the most support and the persons who need the most help may not be the ones able to have things at home in terms of exercise equipment at home, safe spaces to exercise within their homes, and access to even able to use online purchasing of vegetables and groceries and so on. So that is one of the impacts that has come out of what I call the lockdown lifestyle. Okay, the next slide, yeah. So the next pandemic, most persons are predicting is going to be the obesity pandemic. So it has failed to really stop this from happening because we're doing the lockdown lifestyles. We're staying at home. We're doing all these things to control COVID-19. But remember, COVID-19 is just one of the many pandemics we're having. And the obesity one that is on its way here is going to be even more impactful because that is going to shorten lifestyles, and we're seeing the increased numbers of persons living with diabetes and hypertension, that it will all cascade into one event. So are we really, and we have to think and ask ourselves, are we really doing enough to stop obesity and to deal with obesity even from now while it's on its way there to pandemic levels? Right. Next slide. So the first thing is the fear of seeking medical attention. So these are some phrases that I've heard in the past couple of weeks. And referring people to hospital, the hospital got COVID, I ain't going there. They say stay home, so I follow the instructions. And people take this as an absolute. So even in an emergency, they stay home. And then they also say whatever is wrong with me can't be as bad as COVID. So they think that even in their stroke symptom, they would rather have that than have COVID because of how bad COVID has been. And the fear of COVID in itself is killing patients with other serious medical illnesses. And this was taken from a New York Times article that a massive education effort, I think, is needed to assure patients with potentially lethal conditions that hospitals are indeed safe. So it is ideal to not have COVID at all in a hospital. But for sure, if you're having a heart attack, that's the safest place to go. So educating patients, yes, stay home, but do not stay home with your life-threatening illness because that in itself is very dangerous, right? Next slide. So we're at a crossroads right now. We have NCDs on one end and we have infectious diseases such as COVID-19 on the next. But the truth is that we're not fighting two different battles. I think we're all fighting one battle. And if nothing else, we have learned that having diabetes and living with diabetes, living with chronic non-communicable diseases predisposes persons to increase infection rates. So if anything, we should be tackling this head on by having persons have their best control of diabetes and hypertension as possible. So in fact, that the risk of you having serious COVID and serious other illnesses is much less. So it's actually one big battle that we're all facing, right? Next slide. So with all this bad news, because it seems like if you don't have to look far to find bad news, what really can we do and how can we really live our best life with diabetes? How can you live really well with hypertension? So there are a couple steps. These are not all inclusive that I would have as my recommendations. Next slide. Focus on what you can change. There are certain limits of things that you can change in this point in time. You cannot go in the gym as long as you felt like before. You may not even be able to exercise the times that you're accustomed to exercising, but you might be able to swap out eating at a fast food restaurant. Instead of doing that, you might be able to incorporate a little bit more vegetables in your plate. There are small things that you can do and things that you can change, even if you look around, even with all the bad things happening, that you can change. And if you can focus on those things as opposed to looking at the whole overwhelming deal of everything. So instead of saying, oh dear, I can't get my A1C down because I can't do, but you can take your medication, but you can make small diet changes even with what you have. So you might not be able to afford the fresh vegetables, for instance, that you may once have been able to afford, but you can maybe use tinned ones. They're not exactly preferred, but if it is what you have within your budget, use those. If you cannot exercise with your friends, maybe you can exercise virtually with them. So there's small things that you can do and small things that you can change that can have a bigger impact on your A1C and your level of diabetes control, right? The next thing, control what you can. This reinforces it again. So instead of you trying to control everything, you can control what medications you take. In other words, instead of saying, I'm not going to go to the pharmacy because I don't feel like going and I don't feel like taking this medication, have that open discussion with your doctor about how you are indeed taking your medications. Because if side effects are stopping you, then there are other options, there are other ways that you can take certain things. Because if you decide that you ain't taking your medication and you pretending, then it won't benefit you any long haul. So it's better to control what you can. So if you can take it, take it. If you can focus on, for instance, exercising a little bit more than before because you may not be working, control that. But don't try to control and don't try to focus on what you can't control at this point in time, right? Next slide. And the next thing is controlling what you are fed. So it's not just food. There are so many forwards and many times forwards, and you think of all this bad news coming at you one time. And I cannot overemphasize how much mental health really relates to your diabetes control. So if you have all this overwhelming information overload and you are just focusing on that, and that can actually eat away at the the energy that you're having in terms of being even able to prepare your food and having time for things that you enjoy. Then you become overburdened. Oh, there's so many things, so many people suffering. And that can play a role in how your diabetes can be controlled. So control how many of those forwards you look at, how much of that information that you're fed, and how that mentally can impact your diabetes, because it can. Control what you can. Right? Next up. And your mental health matters. I say that this has been a very busy season for all the psychiatrists, psychologists, and mental health professionals in general, because everyone has had some person that they know of, if they're them not themselves, has had anxiety, depression, and we can't overemphasize diabetes distress. So having a chronic disease of any kind is very distressful, because you can't you can't have a day, or most people wake up every day thinking about it. How is this going to influence my day? Am I going to be good today? How is my sugar going to be? And now you have the additional stress of all these other things happening. Have you really taken time out for your mental health? So have you had time to self-reflect and do things that you enjoy? So even within the confines of home or wherever is your safe place, have you taken time out to relax? If it's watch a movie, read a book, learn a skill, do things that you enjoy that are not even related to work or diabetes. Working from home for most persons has resulted in them doing like this all day, and then they end up with back pain and so on. Have you been taking breaks up from your computer screen? Have you been able to just have times of stretching and relaxation? So make sure that you take time out for your mental health, because that can impact diabetes control. Levels of anxiety and stress can impact diabetes control more than you know. Right? And next up, we're soon at the end. And the last slide is basically there are other things than COVID. We cannot only think of COVID. We have to think about everything else. What I mean by this is that if you have chest pain, shortness of breath, don't immediately think, oh, there, I only got COVID. And I want people to know that I got COVID. But think you still should seek medical attention if you have symptoms of something serious. So don't let the fear of COVID and the fear of everything associated with COVID stop you from living and experiencing, and don't stop you from seeking help if you do need help. So in all these things, just remember, we are all having difficult times, but they might be difficult for different persons for different reasons. But make sure that you do pay attention to your diabetes wellness and take small steps to ensure best control. Okay, thank you. That's it for me for right now.
Thank you, Dr. Lovell. I was looking in the chat and I haven't seen any questions as yet. So if there are any questions coming out of the group, can you feel free to turn on your mic and ask Dr. Lovell the questions, or would you like me to start? I'm going to give you a chance to come in. If you don't come in 2 minutes or so, I will ask Dr. Lovell some questions for you.
Good evening.
Good evening.
Yeah, Robert Daniel here. In terms of your presentation, I heard Dr. Lovell mention about the fruits and vegetables and person having access. I would just like to say that there are some persons who deliver the vegetables, so persons don't necessarily have to leave home to go to the supermarket and get. Um, they can call the person and the fruits and vegetables will be delivered to the homes. So that's an avenue that can be explored. In terms of exercising at home, basically speaking, a chair and a 6x6 space is basically all you need to get to do some basic exercise stuff. Turn on your TV to YouTube channel and click on the videos and go from there. So that's an option that can be explored as well.
Thank you for your comments, and I hope persons that required that information would take note of it. Anybody else has any questions?
Mine, good evening. Mine is not a question per well, yes, I heard Doctor did mention something about as far as the vegetables are concerned, you can use the option of tin veg, but most of the times we are told tin veg has in a lot of sodium, and then like persons that suffer with hypertension, that is a disadvantage also.
So right, I was not saying that the 10 vegetables were the same nutritional content even as the other ones. But honestly, I have seen people that they only have money literally for donated vegetables and rice. If all you have in your pantry right now is rice and peas even, or rice and some 10 vegetables, by no means going to starve because you don't have those other ones, which is what some people do. They say, well, I was told I can't use them. And I'm like, but if you only have that, that is literally all they have. They have no disposable income. I have had persons that were telling me they can't exercise because literally in their house is very overcrowded, and to go outside is actually quite dangerous because people are shooting outside. So if you have the ability to use fresh vegetables, for sure, go ahead. If you have the ability to even use the frozen ones, go ahead. But again, there are persons, even within the context of our communities and so on now, who literally have nothing. And is increasing. I'm seeing more and more people increasingly telling me they only have rice and peas, and that's it. And I mean like not even the 10 peas, the ones that use soap and so on. So that's all they have. So it's getting your blood sugar control with that. Like, how do you really adjust for that? So there are much different times that we were even living in before that we could say, oh yes, use the 9-plate model, oh worry about this and that. But there are other strategies right now, right? Or other problems I would say right now.
Thank you, Dr. Lovell. I have a question. Well, you know that COVID-19 is not now, but before it was the talk of the day. So how would I know if I have COVID-19 and not the flu?
I didn't hear the last part.
How would I know if I have COVID-19 and not the flu?
Okay, so they actually present quite similarly. So you can have a fever, the body aches, the chills, but loss of taste and smell are two things that are more likely to be happening for COVID-19 infection as opposed to the flu or even dengue fever. The only way to tell if you have COVID-19 as opposed to other things, because dengue might present similarly, the flu might present similarly as well, is to actually get tested. So you still can get community-based testing for COVID-19 infection. I think Winston Scott Polyclinic, Fast Track, and some other polyclinics are still doing it. It changed, I think, slightly depending on if you were symptomatic or not, but you can consult with your polyclinic because if you do have symptoms of fever and chills and all that, if you have dengue infection, you need to have a slightly different treatment than COVID-19, of course.
Thank you. Any more questions?
Good evening. I'll put one in the chat. If the diabetics are scared of COVID-19, should they have a PCR test? How, where, and when?
Okay, so general community-based testing, they have satellite pop-up centers, I believe this week, in communities with high amounts of it. However, you can go, if you have no symptoms or you just want to get checked, most of the polyclinics are just doing asymptomatic testing. But the last I heard, it was just the gymnasium as well as Winston Scott Polyclinic that was doing symptomatic testing.
And just as a follow-up to that, when I hear reports of, being devil's advocate here, when I hear reports of cases, deaths, you hear that they had comorbidities. Why is it that diabetics don't do too well when they get, if they get COVID-19?
So it's not just the having diabetes, it's also the level of control of your diabetes. So having diabetes that's poorly controlled has a poorer outcome than if you have diabetes that is well controlled. Having diabetes in itself leads to certain other events which increase the risk then of severe COVID. I don't know why they always say comorbidities, because it kind of brands persons with diabetes, because they used to say, oh, they had diabetes and hypertension. And for some reason, persons actually thought that if you had diabetes, you cannot get the vaccine. And I've heard a lot of persons saying, but can I get the vaccine even if I have diabetes? I'm like, you're the person you want to get, because you don't want you to get severe COVID. So that was a big myth that was going on as well. But diabetes, hypertension, any chronic illness, especially chronic lung diseases as well, can increase the risk of it, of severe COVID.
I have a question. Are people living with diabetes at a higher risk of contracting COVID-19?
Originally, it was thought no, but recent research has actually thought yes. But there is nothing stating, or I haven't seen any recent research on persons living with diabetes who have had full vaccination and their level of risk of contracting COVID. Why I say this is because now they're saying that if you are fully vaccinated, you have a less risk of transmitting it, and actually becoming infected with it. Less risk, it doesn't mean you don't get it. Less. But we don't know if persons living with diabetes actually, if they have been fully vaccinated, if they also are even a lower risk.
Thank you. Are there any more questions from the participants? Is anything else anybody would like to know from Dr. Lovell?
Hi, good night.
Good night.
Hi, if somebody was tested, a diabetic was tested positive for COVID and they were asymptomatic, what is the time period after can they be vaccinated? Saying that they would have the antibodies in their body still. Hello?
Unmute
Dr.
your line.
Lovell, remember to unmute, please.
Right, I unmuted now, thanks. Right, so this one, I am actually not sure the level, because we do not check, you don't test out of the isolation facilities anymore. So I am not sure if you have to wait the 6-week period or 3 months or whatever, but I will have to get back to you on that.
Yeah, Dr. Lovell, they actually
Okay,
say, the
thank you.
CDC says it's 1 month.
1 month, right?
4 weeks.
Thank you very much, Dr. Lord.
Thank you.
You're welcome.
Another question. What should I do if someone in my house contracts COVID-19 as a diabetic?
So
I am a diabetic and the person in my household has the COVID-19.
right, so it'll be the same protocol in terms of they will have to do the contact tracing. You will have to be self-isolating and doing the testing. So it would only change then if you had diabetes, if you had COVID-19 infection, but you'll still have to do the isolation and quarantine and so on.
Good evening. There was someone who had just unmuted themselves to answer a question, possibly. Can you please unmute yourselves again? Okay. Is that okay, I have a question, not necessarily for Dr. Lovell, but I have a question for you, the participants who are in on the meeting. Has any person visited their health facility and been turned away? So you were seeking urgent medical attention and you were not able to see the doctor. And if I get no responses, I'll be very happy with that. Lovely. Something that I was worried about, but since no one has answered, I will say that that's wonderful that everyone who has sought medical attention has been able to receive it.
Is there anyone with another question or a comment, a suggestion, anything? Would you like to say it?
Yes, sorry, good evening. How can I contact Dr. Lovell?
You can contact me, or my email address is laura@lovellmedical.net. I don't after. I'm not sure how the host wants to.
Dr. Laurel, maybe you could type it in the chat and they could copy it from there.
Any other comments, questions, suggestions? Come on, we have a doctor right here to answer any question that we have. This is your time to answer any queries, any myths, anything that you've heard and you want to know. No, just ask away.
Hi, good evening. I have a question. Y'all can hear me?
Yes, please, we can.
Okay, my question is I've been diagnosed with diabetes and I'm on medication. My thing to you, doctor, I just want to know like what are some of the should I say I find that my numbers are a little high sometimes. What are some of the best things I can do to control these high numbers?
Right. Step one is to actually discuss this with your doctor. And if you have not seen a dietitian, to also incorporate going to a dietitian as part of the management. Why I say this is because if you are having gold dust, you are using gold dust medications, top line medication, you're taking it every day, and then you decide that you're gonna go and have the special from whichever fast food chain you want, the largest soft drink after each meal, and if you have poor diet, it can start bad, end bad, right? So instead of going on some cleanse or some juicing or some random herbal thing, just speak to your dietitian, but also have that conversation with your doctor. Because if you're saying, well, I'm waking up and my blood sugar is still 20, what's going on here? Have that discussion with them because they actually want you to tell them all those things. If you have blood sugars high after meals as opposed to only high in mornings, that's going to be a completely different regimen for you. But if you have a bad diet, or if your diet is not what is advised, then that can be a starting point of where your blood sugars are, right? So as I say, start with a dietitian, but also have that conversation with your doctor.
Thank you.
You're welcome.
One question I have, Dr. Lovell. You might be having say, your average blood sugar level at, say, 7.2. Is there still a specific range between the 5.5, which is the recommended, and say around 7 that is still acceptable?
So again, that is individualized. With younger patients, we might actually, like for instance, in the teenagers and young adults, we can actually push it as low as 3.9 in certain circumstances. But generally like 4 to 6.5 for very young persons. In an elderly person, I might not even go nearly like that. You might just go 6 to 7 or even 6 to 8, depending on how old they are and their risk for having a low blood sugar. So just like A1C is very individual, having your blood sugars, and that is your fasting blood sugar, I'm assuming you're thinking of, having a blood sugar value is very individual as well. If you were somebody on the pump, you can actually have very tight control on the insulin pump. So as a result, you might be fine waking up with a 3.9 or 4.0, and that might be a very tight range that you run between like 4 and 4.5 or whatever. But again, that is not for everyone, right? So if you're a little granny, you live alone, there's no way I'm going to tell you to go out at 4, because if you get a low blood sugar, that no one's going to be there to help you. But with, as I said, the adolescents and so on that are very strictly under control, then you may have a smaller window or a narrow window, right?
Yeah, thank you very much.
You're welcome.
I'm going to give you some more time just in case anybody else has any questions and they're thinking about it still. And then after that, we will wrap up. So feel free to answer your questions before we go.
I have a question. This goes back to a comment that Dr. Lovell made in terms of monitoring your blood sugars. So I hope that everyone who's in on the meeting has access to a blood sugar machine that's working well. And if it's not working well, you need to contact us or contact the representative for the machine so you can get your blood sugar machine back up and running, because we don't want persons in a situation where they're not able to measure your blood sugars. I'm also going to add this comment, and I think Dr. Lovell mentioned it as well. Stress can actually cause your blood sugar to go a little bit off the norm for you, and therefore this has been a very stressful situation for most, if not all of us. And the events of this weekend has only made it worse. So therefore, getting back to that mental health element is very important because it really can have an impact on your blood sugar. So as I said before, if you have a blood sugar machine which is not working or you're having any issues with it, you can give us a call or you can give the representative a call. And please bear in mind that we are going through a very stressful situation, and therefore that can have an impact on your blood sugar.
Yes, and as I tell patients, like if you're going through stress, you're not exactly, or most people don't exactly eat celery sticks and broccoli. So this is the time that people are like, oh yes, let me bake, let me make all the nice foods. And then they eat the products of their baking. And then they eat all the snacks in the house. So it's just a nice comforting thing to eat all the parts, all the things, right? When you are in a stressful circumstance, but also when you're indoors, when you're in a confined environment. So this is the salt bread baking time, this is the cake eating time, and the biscuits and those things. And the continual nibbling at the fridge, because during the days seem longer. So you're always opening the fridge door, you're always eating. So all that continual grazing actually impacts your blood sugar, because it's like you can't even get a low. You're not nearly going low. So just be more conscious of that behavior as well, because some people are like, I'm always going to the fridge door. So you're not alone. It happens to all of us, but just be more mindful that that also impacts your blood sugar as well, right? So apart from the HbA1c, are there any other tests that persons living with diabetes should have, right? The answer to this is yes, for sure. Number 2 is kidney tests, because you need to know your level of kidney disease. And if you do have kidney disease, you also need to know your cholesterol level, and you also need to know your liver function level. The other ones are peripheral ones, like your blood counts, and with men, especially because if you have diabetes, you're more at risk of erectile dysfunction, so you can have like screening for that. But for sure, kidney tests. If you have not done your urine kidney test or your ACR test, as well as your blood kidney tests, those are the 2 things that you definitely need to get done at least every year. Right?
Thank you. Question on that point you just mentioned about the kidney test. Where can you have that done?
Right. So your doctor, I don't think that you do that at the association, right? It's just the A1C.
Yes, please.
Right.
Laura, for now. For now.
For now, right?
That's
so,
coming.
Okay, good. So there's a urine kidney test that can be done at your doctor's office. They can send it off to the lab, or they can do the portable machine for it. And there is a blood kidney test that also can be done at your doctor's office. So they're usually not point of care testing, or not usually testing that you'll see in like a pop-up shop. But definitely kidney disease here is rampant, I would say. We have so many persons living with kidney disease, and it does not have any symptoms like what people might think it does have. So if it probably turned people's hair blue, maybe we would know, but we don't. It doesn't have any of those symptoms. So you only know if you get screened, and you need to get screened regularly. Right.
Dr. Lovell, there's a question coming from YouTube, and it says, I went to the polyclinic for my meds, but there was no Humulin 70/30. I am now switched to Novolin 70/30. How should I make the switch?
Ideally, I hope that Trudy's hearing this. Ideally,
yes, I can hear you.
Your pharmacist should have told you can just make the equal switch in terms of numbers to numbers, right? There was a stage at polyclinics where I was hearing that there was no insulin in general at some polyclinics. So if you're on insulin and you don't have your insulin, or you don't have it available at the polyclinic, please get a new prescription, and if possible, purchase it, because the effects from you not having that control until God only knows how long the polyclinic takes. It's not worth it. As the $12 it takes or whatever to get it from the private pharmacy. So make sure that if you are on insulin, you can get the other one. But Humulin to Novolin is an easy switch. It's just unit for unit. Okay. But of course, discuss these things with your pharmacist as well as with the doctor, because you can get a new prescription written and you can get it from an outside pharmacy. Right.
I just want to add to that comment as well, because this is a very important point. For those persons who are on insulin managed diabetes, insulin, do not walk away from the polyclinic, pharmacy, or the hospital unless you are leaving with insulin that we may not have in stock, right? The other challenge we are having, and this is a global challenge, this is not unique to Barbados, because we import most of our medications, we are having some difficulty getting medications the way we used to get them before, because we're having disruptions because of COVID, right? So what we're trying to do as far as possible is to make sure that if we're out of one item, that the doctor substitutes with another item so that you can continue to have control of your condition. So that's very important to take note of. Like Dr. Lovell had mentioned it before, in terms of going and getting your medication or having your medication delivered to you, but making sure that you continue to have access to your medications. So even though some of the responsibility lies with you, some of it lies with healthcare professionals, but we need to make sure that everybody is doing what they need to do. Okay?
And another question coming from YouTube, and this is coming from, again, from Gail Ellis. She says, can I get extra syringes from you? And this is towards the Diabetes Association, if I get my meds from the polyclinic?
Yes, you can. So once you are a registered member of the Diabetes and Hypertension Association of Barbados, we have supplies that we have shipped in on a regular basis in excess of what the demand is. So if you need extra syringes, you just need to come to us and we will provide those for you.
Yes, we have another comment from YouTube, and this is coming from Victoria. She says, we have to teach persons to grow their own food, cabbage, lettuce, kale, beans, etc., in small spaces like bleach bottles that you usually throw away. And that's a suggestion.
Thank
That's
you
actually
for,
oh,
go ahead, Dawn.
I was saying that's very innovative, because I mean, there are some people that told me that they were trying to grow things in half cans around their apartment, and then the landladies, or landlord rather, told them, no, y'all can't do that around here. So if you can do it even in a smaller space, then that's very innovative.
Yeah, so the association has also been another group in terms of providing persons with own gardening at home to grow their own vegetables, fruits, whatever you're so inclined to do. So therefore, we should be able to roll that out perhaps in another few weeks or so. So we will see what we can offer you and how we can assist you.
One other question. This is coming from Alicia Ali. It says, good evening. Are there specific signs to look for in children to detect diabetes?
Okay, so it depends on if it's type 1 or type 2. In children, no. When I was going to school, it was, oh, if you're a child, you have type 1. But it's not so clear cut anymore. So just to let persons know, type 1 diabetes means your pancreas is no longer producing insulin. So as a result, you need insulin to survive. Type 2 diabetes usually used to occur later on in life. And it was because your body may be producing insulin, but it's not enough, or it doesn't work very well to actually sustain your daily life. So if you are still producing insulin of any kind, you are type 2. or you have type 2. So in children, you might have increased the same symptoms as in adults if they have symptoms, which would be increased thirst, increased urination, lots of frequent urination at night, weight loss. That's usually associated with type 1. However, type 2 are usually children who are overweight or obese and have a family member with diabetes. Even if they haven't had any symptoms, most pediatricians would still do a random screening for them because they're realizing that even without the symptoms, a lot of them have underdiagnosed type 2 diabetes from very early ages. Because even 2-3 years ago, I wasn't seeing persons with type 2 underneath age 16, but now I'm seeing 12-year-olds and 11-year-olds with type 2 diabetes. And they're being managed in the polyclinic, not only in the hospital setting, because there are so many of them, they can't even hold into pediatric clinics anymore. So as a result, you still need to screen them because it's much a bigger problem than we think. And if you, a parent, has type 2 diabetes, you have a child that's overweight or obese, then they need to be screened too because it's in their genetics. So, and in their lifestyle with having the increased body weight. So they need to be screened as well. Right.
Just we know we're coming to the closer to the end of the presentation, but Kevin says my friend got a vaccine and got a fever, and Kevin says I'm not about getting fevers. What do you have to say about that, Dr. Lovell?
Okay, so that means vaccine worked. Okay. My thing with the vaccine is when you get a nail job and you go to the doctor, the first thing everybody asks, "Oh, I want your tetanus shot." They don't know if your tetanus shot made it in there or what. They want your tetanus shot. And the reason we don't see tetanus anymore is because the tetanus vaccine works. The same thing with polio and all these other things, the vaccines work. So the fact is, if you're getting the COVID-19 vaccine, any vaccine rather, and you have a fever right after, that is your body's immune system kickstarting to produce that response so that when you are exposed to the actual virus, the vaccine does what it's supposed to do. So I got the vaccine, I got a fever, I took 2 Panadol and I was fine. So you will get over it. 2 days max and you're fine. So that should not be your only limiting factor, because if you had to get a flu vaccine, like I got a flu vaccine at a time and I was very sick. I wasn't as sick with the COVID-19. Does that mean that I am different? No, but everybody's very individual. So don't let your friend's experience affect your experience either, right?
Well, I don't know if you would take one more, but from the chat, it says, good evening. Apart from having a HbA1c every 3 months, are there any other tests that diabetics should have frequently?
Oh, I had answered that previously. That was the kidney test one.
Okay, well, that's covered then.
Dr.
Good
Lovell, I'll
evening.
just add one more thing
Hello.
before the next question. In addition to getting the test for your kidney function, it's also important to get your blood pressure measured as well, because we want to make sure that your blood pressure and your blood sugar are well controlled. So we need to make sure that you're measuring your blood pressure as well. That may happen at every visit that you go to a health facility, but it's very important that you have your blood pressure measured as well, because in Barbados, our statistics actually reflect that we have more persons living with hypertension than persons living with diabetes. And the complications can be the same. So we need to make sure that the same way we're measuring for your blood sugar control, we're also measuring for your blood pressure control.
Hello, are you
My
open to joining? Hello, are you
Good evening.
open for joining?
Are you open for joining the association?
Yes, please.
Of course, we had many members and hosts.
Pardon?
Yes, we are open for joining. If you're interested in, pardon?
Yeah. Yes, what are the times?
Our office
The
hours.
days?
Pardon? The days to come to the association?
Yes.
Okay. We're open Monday to Friday between the hours of 9 and 4:30 in the evening. You can come. Do you know where we're located?
Yes. At
Well,
the
I'm
corner
good.
of Jessamy Avenue.
That is correct. So you can come in at any time and just let them know, let the
Right.
staff know you want to become a member, and they will take you through the process.
Okay. You have to, what's the subscription?
The cost for membership is $25 per year or $100 for 5 years.
Okay. Thanks very much, Lee.
You're welcome.
My question was relating to the cholesterol. Is it necessary to get your cholesterol checked as often as the blood pressure and diabetes?
No, it's not. So cholesterol can come with your annual test. It can even go as long as every 2 years, depending on your level of control and your risk factors. So it's usually an annual test.
Thank you.
I'm seeing a comment here in the YouTube chat that the person, Victoria Tarnford, she's saying that she thinks that children should be screened if they are in a family with a diabetic history.
Right. It depends upon the child. Usually children should go for a well child visit every 6 months to see their normal development and milestones are being met, right? So at that visit, the pediatrician or the doctor would make that determination. But widespread screening wouldn't necessarily be the norm or be the recommendation. It would be individual and situation dependent. So for instance, if you had type 1 diabetes in one child and you had another child, what some persons do, like in North America, the test isn't already done here, they can actually detect when that child or detect certain factors in that child's blood that can actually tell them if this child is going to have type 1 or not. But again, that very expensive screening. So some people just wait it out and see. But yeah, that would all depend on the child at the well child visit.
Thank you, Dr. Lovell. I'm going to say that I'm going to give you a chance to ask one more question before we wrap up. So if there's anyone that has another question, please ask it now so that we can close off the webinar.
I see that there's another question from a Sandy B. Her question is, do you recommend having insulin production levels checked?
So the insulin production level would be your C-peptide value. Routinely, we only do those in type 1 persons. It isn't a routine test that we would do.
Can you take
And
one
just,
more? I see one more.
and just as I was going to say that
Yeah.
we're going to, there's a question that just came in. The question is diabetes really hereditary or is this a myth?
Nope, it is not a myth. It is type 2 diabetes does run in families, as we say. Type 1 also has many different factors, but one of the factors for both of them, as we say, is genetics. So you don't have to look like a diabetic, whatever that look is. But genetics does play a big role, right?
I think the look is the myth.
Yes, it is, because then you'll be like, but you don't look diabetic. Nope,
Exactly.
There's no look.
The look is the myth.
Yeah, there's no look. I tell people that Halle Berry has type 2 diabetes. Does she look like the pictures of type 2? Nope. So, yeah, there's no look.
Thank you, Dr. Lovell. So we're going to wrap up this webinar this evening in a couple of minutes. And I hope that whatever was said, questions that were asked, anything that you wanted to know that you found out, and that you can take away from it and share with others. So let's wrap up. First, we want to thank you, Dr. Lovell, for giving of your time and sharing your knowledge with our members and the public. We would also like to thank each and every one of you for signing up and joining us this evening. We hope you found this session insightful and informative, and you can use the information acquired to the benefit of yourself and others. If you have any questions or queries, or you're interested in becoming a member of the Diabetes and Hypertension Association of Barbados, feel free to contact us by telephone 427-9338 or 437-2285, by email at dab408@gmail.com. You can also find us on Facebook at the Diabetes and Hypertension Association of Barbados, and on Instagram at DHA Barbados. On behalf of the Board of Trustees, the executive staff, on behalf of the Board of Trustees, the executive staff, and members of the Diabetes and Hypertension Association of Barbados, thank you for joining us. Stay safe and have a good night.
Good night.
Good night. Thank you again for having me.
Good
Good
night.
night. You're
Thank
welcome.
you.
Good
Good night.
night.
Thank you.
Thank you.
Night and thank you.
Good night.